Good morning, everyone. This is my third year being part of this conference, and I'm very glad to be welcomed back. I want to thank Dr. Shaw for having me for the third time. The first two times that I presented, if you all can't hear me, just let me know. I'll do the best I can. The first couple times that I presented, I spent a lot of time talking about the neuropsychological evaluation. That's something that's a little bit of a mystery to folks. It's a little bit different activity that folks are used to participating in with a psychologist. Neuropsychologists have additional training in assessment of brain and behavior relationships, and we use standardized tests to draw some conclusions that I'm going to share with you. I'm going to talk with all of you about this morning. I'm going to also talk this time a little bit more about what we do with these findings. Now, certainly we are using the data that we gather to help make sense of the effect of the condition. We talk about other conditions that may be affecting the brain, other disease processes that may be present that require some type of clinical management. But I want to talk with you all a little bit more today about what to do as far as compensating for some of these areas of difficulties that we may identify. The topics that we're going to be covering today, as I mentioned, we're going to talk a little bit about some of the specific cognitive changes that are more common with Parkinson's disease that may be a little bit different than some other neurodegenerative conditions or other diseases that affect the brain. I'm going to talk with you a little bit about how common some of these cognitive changes are. To some extent, we're going to talk a little bit about what causes these changes, although really in the interest of time, we won't go into a whole lot of detail as far as the neuroanatomy, neurophysiology. Most importantly, we want to talk about coping. What do we do with what we find? I am struggling with this slide answer. Okay, so what exactly is neuropsychology? As I mentioned, I'm a clinical psychologist with additional training in neuropsychology. And what that is the assessment of brain and behavior relationships. This is a non-invasive technique where we're looking at cognitive change associated with a particular presentation, a particular disease. We evaluate memory, we evaluate problem solving, and we use standardized tests to draw some conclusions that we hope are helpful for the individual to understand, and especially their referring provider. The types of evaluations, or rather the types of patients that we see in our clinic, are quite diverse. I see patients 18 and older. Sometimes we'll see patients for neurodevelopmental disorder evaluations, so ADHD, autism spectrum disorder. I do a lot of work with survivors of traumatic brain injury. Cerebral vascular disease was mentioned in my introduction. I also have, of course, relevant to our discussion today, a very strong interest of movement disorders in the spectrum of Parkinson's and Parkinson's plus phenomena. And so my interest is to find out the effects from a thinking perspective, or the non-motor effects associated with movement disorder. Now, as a psychologist, I would be remiss in not also evaluating psychological well-being. That is certainly part of our evaluation. And we'll talk a little bit later in the presentation about how mood can affect thinking. We can't really separate, nor can we really separate some of these cognitive domains, if you will, attention from memory, from problem solving, because the brain is a network. There's a lot of interaction in the brain that's going on both deep within the brain and in the cortex, but certainly mood and other non-motor factors associated with different conditions can affect thinking skills as well. So we talk about things that are going on, that are the changes in the brain that affect thinking, but also things that act upon the brain, such as depression, anxiety, sleep-related concerns, those types of influences. So we'll talk about that in just a little bit. Now, these appointments are fairly long. We usually schedule these evaluations for about 4 hours. Now, that sounds pretty intimidating. That's a half day of putting your brain to work. And that can be a little scary when our support staff says, okay, we'll have you here at 8 o'clock and you'll be done by 12. That's a long, long day. Or you're here at 12:30 and we'll get you done before the sun goes down. But now there's a lot of things that go into this evaluation. It's also important to know that we ask folks to allow for this amount of time in either the morning or the afternoon, because we want to incorporate breaks. We want to incorporate some downtime if needed. And sometimes we'll have a scenario where, for various reasons, we are only able to do a certain amount of testing. So certainly if someone is less capable of enduring a 4-hour evaluation, we're not going to be pushing you far past your limits. So it's also important to point out, too, that typically the first part of the evaluation is an interview. I will receive a lot of information either from our neurology colleagues, sometimes our neurosurgery colleagues, sometimes family medicine, other providers within the healthcare system that details kind of what you've been through, your medical background, maybe neuroimaging, and other types of tests that are being done. I'm taking a look at that as we're finding out not just why your doctor wants you to come in to do this evaluation, but what you're noticing. We like to have family present as well. I say this a lot when I give presentations about traumatic brain injury, but I think it applies across the board, probably in most conditions, certainly most neurological conditions. But a disease process doesn't just affect one person. It affects a whole system of people. And so we like to incorporate that system as much as possible. It's always interesting when I go into one of our clinic rooms and we don't have enough chairs to accommodate the family. That's so big. And I can always sort of draw from that the degree of support that someone has. And that's going to be really, really important information. While we put a lot of stock into the data that we collect, the numbers that we draw from our evaluation, you and your family know yourself better than we do. And we're not going to assume for a minute that our data, that our numbers, tells us more than you already know, but we're going to add some elaboration to that. I'll use an example. People will often comment on memory difficulties. There's lots of different types of memory difficulties that are common and unique about different disease processes, but there's also things that go into memory that we may not realize. So, for example, sometimes when someone reports having memory difficulties, when we do the evaluation and we find out that maybe their memory is actually okay, but it really takes them a long time to process information, or they actually get a little bit more distracted than we would expect them to be at this stage of their development. We can comment on that says it's not really just a memory problem. I think you're being distracted by things, or there's times where your thinking just isn't as quick as it used to be. That doesn't necessarily mean that you can't hold on to that information. Now, in Parkinson's disease, that's going to be very different than by comparison of a different type of degenerative condition, such as Alzheimer's disease, where there's a different type of forgetfulness, where we refer to that more so as amnesia. Now, so we talk about what this process is like. So we're reviewing records, we're finding out about you, okay? We're hearing from collateral supports. Sometimes that can add an additional layer to what information we already have in the record. And then we transition into the clinical testing. We use technicians within our university system, so I have 3 technicians that do the standardized testing. Now, what do I mean by that? So standardized testing, again, as I mentioned earlier, this is non-invasive. We're not hooking electrodes up to you. We're not doing anything that should cause pain. I will tell you that sometimes people say, this was tiring, and I now have a headache. I don't ever want to do this again. I had one patient recently and said, this was fantastic. More people should do this. I had so much fun. And I said, I really wish you could be a spokesperson for our service. If you could create a soundbite and put that on our link or for our webpage, that would be wonderful. But that is unfortunately not necessarily the most common consequence. But if that is, that's great. We are certainly using this information that we gather to communicate back to you and your referring provider. Now, so why does this matter? So when we use these measures, when I say standardized, that means that we're administering these tests the same way every time. So we're evaluating attention, memory, problem solving, spatial judgment, and much of this is by way of paper and pencil testing. Our technicians, of course, are doing most of the writing, and they're asking questions. They're reading a list of words, finding out how many words that one can remember over a period of time. And that gives us a lot of information about how the brain is working. Now, what's important to know is that we use normative data. So what that means is we compare findings on testing to samples of individuals of the same age and education. And so none of us would be or should be expected to remember the same amount of information or think as quickly as we did in our 20s. That thinking speed, we're all shaking our heads. That's very, very true. In my 20s, I probably could have figured out this clicker much easier than I could today, right? Okay, but that could just be part of normal aging. The first question that we need to answer is, are some of the thinking difficulties that you're having, is that to be expected at your age and maybe even background? That's the first question that we want to ask. Is this normal aging? And if so, we can give a clean bill of health. Or is this, meaning the difficulty that we're observing, is this beyond where we would expect someone to be at a particular stage of their life? And so in other words, is that an outlier? And we do this by way of a statistical analysis that takes a lot of time. It takes a fair amount of time to come in to see us, but it takes a lot of time for us to do the evaluations on the back end. There's great care that goes into all of our providers that offer care to movement disorders. Neuropsychologists are no exception to that. We spend an awful lot of time, quote unquote, on the back end doing these statistical analyses and trying to make sense of all this information that we gathered over a 4-hour period. Okay. So, what are common thinking changes? Most people will come to our clinic and reference the change that they're experiencing as if it's memory. That's a common observation or difficulty that we may notice. If someone has a language problem, it's not uncommon for folks to say, I'm forgetting words. Or if I'm having troubles with completing tasks, with problem solving, I'm forgetting how to do things. Now, when we do this evaluation, we try to untangle whether or not that's really a memory problem or if it's something else. And when we think about the something else, we look at what the common changes are associated with Parkinson's disease. Now, I do say common because everybody's different. If everybody is the same, one size would fit all, and not anybody would have to come in and do this evaluation. We could just say, you've got the condition, we know what the problems are. What are typical is this slowed thinking. And this mimics the slowed movements. When we talk about the phenomena known as bradykinesia, the slowed movements, we think of the analogous version from a thinking perspective as bradiphrenia, slowed processing of information. Memory slippages. This is a little bit different than memory changes in other conditions. People may say that I know what it is, but I just can't come up with it. The information is there, but it's hard to retrieve. And if we use a comparison with another condition where there is more extensive amnesia, that information isn't there and can't be retrieved. When we think about movement disorders, because of the physiology associated with change, there is difficulties with retrieving information. It's not that information is lost. The other piece that's really important too, and this is, which is very true mostly across the board with the types of conditions that we evaluate in our condition, people will often remember old information. Now that seems a little counterintuitive. So people will say, my memory's just fine. I remember things from 30 years ago. And it's important to distinguish that type of memory, that long-term memory that's stored in various parts of the brain, to learning new information. And then the problem may not be, it's not that I don't remember my wedding day or significant events in my life. I forget conversations day to day, or forget what I was doing earlier. And again, that sounds a little counterintuitive. Why would it be harder to learn new information and retain new information rather than that old information? But it makes sense given the types of changes that are going on in the brain. In other words, the areas that are affected are not so much those areas that store the old information, but affect the learning and encoding of new information. And that's really, really important. Troubles finding words. Again, being on the tip of the tongue phenomena. There's a word, I just can't quite think of it. And a lot of people will talk around it. Something like they'll come up with a word or describe a word rather than getting to the point and use the actual word that they want. It isn't necessarily that their use of language is gone. It's difficult accessing that information that they once were able to do much more easily. And problem solving, thinking flexibly, being in a new situation and figuring out what to do. Those are some of the changes that we commonly see, and we want to comment on what is unique about the individual that we're evaluating. Now, when we think of Parkinson's disease, and again, I mentioned earlier that we were going to talk a little bit about what causes these changes. That could be a whole different discussion in and of itself, probably a whole different seminar. Essentially what we're talking about are those brain circuits that are affecting the ability to initiate movement or to catch themselves when they're falling or causing the rigidity. Those brain centers also have some role in cognition or thinking. Certainly the neurotransmitter changes that go on in the brain that are hopefully compensated for to a degree by dopamine replacement treatments are the areas that can affect the different types of thinking that I've already described. And so what do we know about Parkinson's and Parkinson's-related cognitive change? Generally speaking, many individuals who experience Parkinson's at some point have some degree of cognitive change. Now, it may not necessarily be present early on. Let's say that an individual experiences a significant amount of cognitive change around the time that they start to experience the motor symptoms. We start to think about something other than idiopathic Parkinson's disease. We start to think about something like dementia with Lewy body, or we even think of a co-occurring condition that can go along with Parkinson's disease. But generally speaking, early on, there may not necessarily be really obvious changes in thinking. Now, there is some literature that suggests that there may be a little bit of forgetfulness or problem-solving difficulties that predate Parkinson's disease by many years. That's not something that's really seen consistently, though. But suffice to say, if somebody were to come in my clinic and they're fairly early on in their course of Parkinson's disease, there may be some mild change that can go along early on. So what then is the point of doing the evaluation? Well, we want to see if this individual does fall into that group of expectation. We want to see, if not, is there something else going on? And thirdly, we want to establish what essentially a baseline would be if that change were to become more pronounced over time. Now, there's a lot of people that will say, well, you didn't know me before. How do you know that I'm any different than I was 10 years prior? There's certain ways that we can look at our neuropsychology data that will give us an estimate of how somebody's ability was before. There's certain things that just don't change over time, even with certain disease processes. And so we can look at that data and say, this is where we think the person was before. There's change from where we expected them to be at their baseline. And we can make those inferences that we think will be helpful for the individual and their provider. The other pieces that can influence cognition, sleep certainly is a major factor. These are things that we ask about, the consistency of sleep, any sort of disruption, certainly a co-occurring sleep disorder, depression and anxiety that can certainly weigh on someone's mind. And depression and anxiety, this may sound strange to say, takes an awful lot of energy takes an awful lot of cognitive ability, and that robs us from the opportunity to maybe pay attention to other things that are going on in our life and learn new information. We also know that depression and anxiety is not uncommon in many neurological conditions, Parkinson's included. Okay. We know that the older someone is when diagnosed, the more likely they are to have more cognitive symptoms. We also know that over time, there's a greater risk of developing cognitive symptoms. So even if someone's younger, as time goes on, because of those changes in the brain that are affecting movement, there can also be changes in cognition that go along with it. We also know that those whose symptom profile is less tremor dominant and more so difficulties with balance, walking, maybe even rigidity, tend to have more cognitive symptoms. And then certainly those, as I mentioned earlier, it's worth repeating, those that experience depression, anxiety, and sleep problems, that can confound the cognitive profile, so to speak, and it's something that we need to make sense of as clinicians. Okay, so what can we do about all this information? Now, I think there's a couple things that I really, really want to point out, and this may sound, I'm going to get the sign, the cutoff sign, so I'll try not to go over. Yeah, a little shaky. I want to make sure that I don't go over. But what's really important to know, when I talked about the common changes that go along with Parkinson's disease, note that one of the things that I didn't say was that Parkinson's disease changes someone's intellect or their intellectual ability. And I didn't mention that because it's true. Now, that being said, it's not uncommon for patients to say, I feel less smart than I was before. I've even had some say, I feel so stupid that I can't remember this information. Believe it or not, intellect is not something that changes measurably in Parkinson's disease. It's one's ability to get that information out. So someone may be just as smart as they ever were, although they may not feel as though they are because it takes them a long time to process information or get the information out. But intellect is something that tends to stay stable for the most part over time, and I really, really want to emphasize that because that is something that we think about when we get a little bit more forgetful. Oh, I feel stupid. I just don't feel as smart as I was before. And this isn't just semantics. I'm not just splitting hairs here. We know that one's intellectual ability is not affected. And so, because of that, we want to talk about ways that can help bring out that intellect and allow someone to feel a little bit more like they were before. I think the reason why I want to preface what I'm about to say about some of the compensatory strategies, I really believe that it's important, number one, to involve a system, a family, if you will. As I mentioned earlier, no disease affects one person in isolation. It's usually a system of people that are affected. So why not bring the system in to help with some of these strategies? But the other piece that's really important too, I want individuals to be doing all the things that they're capable of doing for as long as they're capable of doing those things. That's a little bit wordy, but those who have Parkinson's symptoms may feel less in control. They can't control their body. It's unfortunate that they're not able to initiate movements like they were before. And then on top of it, there's symptoms of depression, there's symptoms of cognitive change. So as much as somebody can do for themselves, the better. That doesn't take all the depression away. I'm not here to say that that's the magic cure. But if somebody can feel a little bit more in control of some aspect of their life, we know that that can make them feel a little bit more like themselves or have a greater sense of self-efficacy. So the strategies that we recommend, we want the individual to start implementing them in their daily life. These are often simplistic, basic kinds of common sense types of strategies. I will say, while I'm not a speech pathologist, our colleagues in OT and speech do a wonderful job of cognitive rehabilitation. And we know from the literature that there's benefit from cognitive rehabilitation with Parkinson's disease. There's meta-analytic studies that show the benefit or the efficacy of these types of interventions. Often it's a approach of compensation rather than restoring. In other words, it's difficult to train the brain to get those abilities back. We work around them the best that we can. And so what are some examples? And I have some written here that I wanted to share. When we're talking about memory, it's really important to use a notebook, a day planner. There are many different apps on a phone that can help organize daily activities. And in this sort of modern technological world, people tend to not really think anything of someone pulling out their phone and looking at their calendar. There's a much less stigma behind that because it's sort of accepted. Organizing the house where there's sort of natural reminders, putting information putting objects, keys, pens, notebooks, those types of things in the same place. Making sure that somebody is maintaining a consistent routine. I think that is one of the major take-home messages here. Consistency is quite important. We also know that if we associate new activities with activities that already happen sort of without our thinking, we can benefit from that. So let me give you an example. So if you are now starting to take medication when you never did before, pair it with something that happens on a regular basis or at a typical, predictable basis. I like to tell people that if they brush their teeth at the same time, take your medication, because at that time, if that's when it's scheduled, if that's how your medication is scheduled, then over time, you don't have to think about taking your medication. It becomes conditioned or almost automatic. And we want to borrow from some of those things that we don't have to consciously think about, because what has changed often in Parkinson's disease is the ability to kind of come up with that on our own or to problem solve independently. We want to take breaks when we're feeling mentally tired. That seems so obvious, but I don't think we think about that a lot. There's certainly evidence to suggest that the on and off periods of medication correlate with the cognitive fluency, the ability to think clearly. And so really the best recommendation during those off periods, don't have that be a time where you're making critical decisions if you can avoid it. I know that sounds very, very basic, but we want to really prioritize those things that are going to require the most mental effort when we have the energy to do so. The difficulties with multitasking are not uncommon. There's not a great way that I'm aware of to retrain the brain to be able to multitask. So essentially, we want to break things down so we don't have to, kind of working around it. And certainly keeping your healthcare provider informed to determine whether there's pharmacological interventions or other types of treatments that can be beneficial to help with those cognitive changes. Certainly asking for caregiver support, being patient, encouraging physical activity and mental activity. We know that the more activity, the more we have in the bank, so to speak, from a cognitive perspective, that helps us once we experience cognitive change. We call this reserve capacity. So if there's a lot of connections formed in the brain, either because of education or other types of experience, the cognitive change is experienced a little bit less. Now, we know that when we're older, we want to keep ourselves active as well. We also know from the research that it's not just cognitive activity. So keeping your brain stimulated in conversations about politics or current events, although sometimes that can that can bring about a lot of emotion, so maybe let's avoid some topics if that's a little heated. But keeping on top of what's going on in the world around you, having conversations with loved ones, but physical activity as well. We know that can be as beneficial as some of the brain games, so to speak, because we're talking about keeping our mind and body active. So really trying to optimize that as much as possible. this was kind of already mentioned. Notice keeping your healthcare provider aware of any sort of changes in mood, personality, or behavior. And that's really important as well. Certainly, as I've mentioned multiple times, it's not uncommon to experience changes in mood, maybe even changes in personality, either because there's something else going on neurologically or just because it's frustrating having to deal with all these changes all at once, and irritability levels change. Those kinds of things are very, very important to discuss with healthcare providers. I think that a good way of looking at sort of coping with physical change is not too dissimilar from grief or bereavement. Now, it's not necessarily the same of losing a loved one, but we're losing a level of independence. We're losing our ability to do things. And there is a grief that's associated with that. And sometimes grief counseling, believe it or not, can be beneficial to cope with physical change. And sort of reaching out to healthcare providers, mental health care providers are critical. And look at that. I think I ended hopefully right on time. I'm getting the thumbs up. So I appreciate all your attention this morning. And there's a number of different things that unfortunately I wasn't able to get to. Maybe Dr. Shaw will ask me back for the 4th year in a row. So hope to see you all again. Thank you.